Good morning. Thank you for the invitation. We have a lot to cover. I would just give two brief statements. One is that doing thalassemia and sickle in the same talk is like doing AML and ALL in the same talk. You just wouldn't do it, but they do it. And so something's going to get the short shrift. And since most people feel a little bit more uncomfortable with thalassemia, I'll spend a bit more time on thalassemia. And that's a strategic decision. And two, this is a board review course, not of what's new in thalassemia and sickle cell disease, so not a lot of clinical trials that have just been published, but what you need to know for the board. So everything in this lecture comes directly from the board content outline. So no conflicts of interest, but we will be discussing some off-label use of hydroxyurea in children. And so we're talking about hemoglobinopathies today, disorders of hemoglobin, but specifically disorders of the protein component of hemoglobin, the globin. The disorders of heme give you sideroblastic anemias and porphyrias. We're talking about hemoglobinopathies, so disorders of the globin chain. And so we have our beta-like globins on chromosome 11 and our alpha-like globins on chromosome 16. And when two alpha and two beta proteins come together, that gives us hemoglobin A. A stands for adult. Now I say alpha-like and beta-like because there are different beta-like globin genes and different alpha-like globin genes that are expressed at different times during maturation of the organism. So here are the coding genes of the beta-globin gene cluster on chromosome 11. There's an embryonic epsilon, the paired fetal gamma-globin genes, and then the adult minor delta and major beta-globin gene. Now, each of these has proper genetic nomenclature, HBE, G2, HBD, HBBB. It's easy to figure out. Just transliterate the Greek character into the English. So beta B, hemoglobin B, HBB gene is what you'll see if you order genetic testing. They won't necessarily say the beta globin gene. Good places will use both, but sometimes you'll just get back the proper genetic nomenclature. So that's one thing to know. On the alpha globin gene cluster, the coding genes are simpler. There's only one embryonic zeta gene, and then the paired alpha globin genes are active during both fetal and adult life. So a bit simpler there. The thing to remember then in adult life is that there is one adult beta globin gene, major beta globin gene, but two paired alpha globin genes on each chromosome. So the normal adult and postnatal life, we're subsisting on two beta globin genes and four alpha globin genes. So that makes the genetics a bit more interesting. Now these change dynamically throughout development, and so here we see on the x-axis age of the individual. The gray line is birth, prenatal, postnatal age, and this is percent of fetal hemoglobin production, total hemoglobin production rather. And those embryonic globins, they really are not detectable after about 8 to 10 weeks of gestation. What we really you need to concentrate on and remember are the fetal and adult globins. And so on the alpha side, that's pretty straightforward. The alpha-like globin is alpha itself during both fetal and postnatal life. A little bit more interesting on the beta-like globin side because the beta-like gene and beta-like globin chain of fetal life is gamma. And so right before birth, several weeks before birth, there's a developmental decline in the gamma chain production. And well, before I go there, let me just mention that two alphas and two gammas, that's hemoglobin F. F is for fetal hemoglobin. Now, here's the developmental switch that happens as gamma globin chain production declines before birth. Beta globin chain production increases. Now, at the time of birth, there's more gamma than beta, so that means that normal neonates will have more F than A, and so a normal normal newborn screening pattern for is an FA pattern. And then that developmental switch is generally complete by 6 to 12 months of age. And in postnatal life, the predominant hemoglobin is hemoglobin A, two alphas and two betas, A for adult. And then there is a minor amount of the other adult hemoglobin, A2, which is the combination of two deltas and two alphas. So this is an important switch to know. Now, there are a number of different names of abnormal hemoglobins by letters and city names and that sort of things, but the ones that you need to know and be familiar with specifically for the boards are shown here. These are the ones I just talked about, the normal A, A2, and F, and then two abnormals that you'll need to know about specifically are hemoglobin Bart's, which is a gamma tetramer, and hemoglobin H, which is a beta tetramer, and I'll talk about how they arise in just a minute. Okay, this is a talk about hemoglobinopathies, and so hemoglobinopathies can be divided into two broad categories conceptually. It's good to think about it this way: quantitative disorders, in which there's decreased production of usually, but not always, normal globin chains. And so thalassemias are the quantitative disorders. There's decreased production of one or the other or multiple globin chains. In contrast, the qualitative disorders like sickle cell disease, hemoglobin C, those are structural variants in which there's production of structurally abnormal globin chains. Now, just to be confusing, sometimes people use hemoglobinopathies to be synonymous with the qualitative disorders, but technically all these are hemoglobinopathies because they're all disorders of hemoglobin. So there are quantitative disorders, the thalassemias, and the qualitative disorders, the structural variants, or the hemoglobinopathies. And sometimes, as we'll see, and I'll point out two examples, some hemoglobinopathies have both qualitative and quantitative defects. It's important to know the geographical distribution, at least the ancestral geographical distribution of the common disorders of hemoglobin. Of course, this changes today because of migration. And so thalassemia, shown in yellow, are common in the Mediterranean, the Middle East, the Indian subcontinent, and down into Southeast Asia. Hemoglobin S and C are most common in sub-Saharan Africa, but can also occur in pockets in the Mediterranean, the Middle East, and India. Hemoglobin D originated here in the Indian subcontinent, and hemoglobin E is especially common in Southeast Asia. We'll talk about all of these, but it's important to know their ancestral origins. Evolutionarily, at least. Okay, so that was hemoglobinopathies in broad strokes. Now we'll talk specifically about the quantitative disorders, rather, the thalassemias. And so before jumping in, let me just review the normal state. And so here we have, go back, pardon me. The normal state here, I'll show you, these are our alpha globin genes and our gamma globin genes. And our beta globin genes are over here. So when we're thinking about children and adults, we're talking about alphas and betas. When we're thinking about fetuses and newborns, we're talking about alphas and gammas. Of course, these gammas are stuck right next to this. So this is not a map of the genes on the chromosome, but a conceptual map of what's going on. So if we look, we have these genes, and these genes make globin proteins. And in the fetus and the newborn, the gamma globin genes make gamma globin chains, and the alpha globin genes make alpha globin chains, and they come together to give us fetal hemoglobin. All right, so that's pretty straightforward. And then on the postnatal side, the beta globin chains make beta globin genes make beta globin chains, and they come together to form hemoglobin A. That's pretty straightforward. The important point here is that there should be a roughly 1-to-1 ratio of the alpha-like and the beta-like globins. If there is not, if there is an imbalance, that's thalassemia. Let's point that out here. Take, for example, thalassemia trait. Here we have 2 gene deletion alpha thalassemia. So here's a fetus and newborn. We'll focus on this side first. Gamma globin chains make gamma globin genes. The alpha globin chains make a reduced number of alpha globin chains. I may have said gamma, but the reduced number of alpha globin chains here. On the childhood and adult side, their beta globin genes do make beta globin proteins. But what we see here is a relative deficiency of the alpha globin chains. You still are able to make hemoglobin F, and you are still able to make some hemoglobin A, but the gamma chains are in excess in neonatal and fetal life, and that results in the production of hemoglobin Bart's. So if you have a newborn screen that has hemoglobin Bart's, that means that this child must have a form of alpha thalassemia. And then the cognate on the in postnatal life is hemoglobin H, which is a tetramer of Bart's. That forms due to the excess of the beta globin chains due to the alpha deficiency. So in thalassemia, there's a deficiency of one, but it's the excess of the other that leads to the problem. And so in alpha thalassemia, there is an excess of the beta and gammas compared to the alphas. All right, so that's pretty straight. So here we can see that both fetuses and children and adults can be symptomatic of alpha thalassemia. Now let's think about beta thalassemia. Okay, so here we have one gene deletion or a beta null mutation here in the beta globin locus. And so we get genes making their globin chains, and they come together, and so you make hemoglobin F. The fetus and the newborn is perfectly fine because they're subsisting on the gamma globin chain, right? And so a newborn, a fetus, even with homozygous beta 0 thalassemia, will have normal blood counts and will not have microcytosis. After that gamma chain production is turned off and beta chain production tries to turn on, well, there's an excess here of the alpha globin chains, and that's what leads to a problem. And those excess alpha globin chains, those are very toxic and unstable. There's no Bart's or H equivalent. It doesn't hang around long enough. It's unstable, it does its damage, and you can't detect it. And so there's no H equivalent in beta thalassemia. And so in beta thalassemia, the problem is excess of the alpha globin chains. Those chains in excess are the ones that are toxic in general and lead to problems. Okay, so this is the pathophysiology then of thalassemia. So there's decreased production of either the alpha or beta, very simply, and that leads to the imbalance between the two. It's the imbalance here that's key. Beta thalassemia leads to an imbalance in there's excess alpha globins. And it's those globins in excess that I mentioned about that precipitate and damage the red blood cell membrane inside the bone marrow as red blood cells are trying to be made. And so this leads to what was talked about earlier, ineffective erythropoiesis. And as a consequence of the ineffective erythropoiesis, the bone marrow is working very hard, but those erythroid precursors are being damaged as they're being made. That leads to peripheral anemia, and then the bone marrow tries to respond to that and make more, but it's ineffective, so it really can't. But there's bone marrow expansion, and then when the bone marrow can't do what it needs to do, there can be extramedullary hematopoiesis, splenomegaly, hepatomegaly, and then extramedullary, sometimes paraspinal hematopoiesis. And also what was alluded to before, increased intestinal absorption of iron. This disease doesn't need iron, but there's an abnormal or pathological signal that leads to increased intestinal absorption of iron. All right. I think one thing that's confusing to many people about thalassemias is the naming, the nomenclature. And to break it down, it's actually quite simple. There's two complementary systems. One, there's a genetic defect or genetic nomenclature, and then a clinical nomenclature. And it's straightforward. Alpha thalassemia is defect in alpha globin genes. Beta thalassemia is defect in beta globin genes. There's delta beta thalassemias. There's gamma delta beta thalassemias. There's gamma thal. Whatever that is, that you just name it after what gene is defective, not the one in excess. And then a complementary system is the clinical severity, and these are basket terms, right? So the minor or the trait state, that's everybody knows that's mild asymptomatic anemia. Major or TDT, increasingly we're getting away from major and intermediate and talking about transfusion-dependent thalassemia. That's severe anemia, and these individuals by definition are transfusion-dependent. And then everything in between there, between very mild anemia and severe anemia, you can see there's a lot in that range. That's thalassemia intermedia or non-transfusion dependent thalassemia, NTDT. And these individuals may have no or infrequent or sometimes frequent transfusions, just not enough to make them thalassemia major. And so then you use these two together. You can have alpha minor, beta thalassemia minor, alpha thalassemia intermedia, beta thalassemia intermedia. So there's the genetic defect and the clinical severity. Those two complementary systems can be used together. So that should be pretty straightforward. And then again, getting away from intermediate and major for whatever reason in the literature to NTDT and TTD. All right, so we'll talk about the alpha and the beta thalassemias, but these are the pearls or the points that you need to know for the boards. In general, alpha thalassemia is most commonly caused by deletions. Segments of DNA, large segments generally that contain those alpha globin genes are just deleted. And we'll show some of the images of these common recurrent deletions. In contrast, beta thalassemia tends to be caused by point mutations that disrupt regulatory elements of gene expression. And you may have heard of beta plus and beta zero or beta null alleles. There's not just one beta plus mutation and one beta zero mutation. There's 150, 200 different mutations that give rise to beta plus, and 100 and 150 or so that give rise to beta zero. So those are also, beta plus is a category of mutations that leads to decreased production of beta globin gene. There's some that's made. It could be 1% of normal or up to 30 or 40% of normal. So a big range there. So all those different severities of the beta plus mutations, if you mix and match with other beta globin mutations, can modify the severity of the thalassemia. And then the beta null, that just means that there's nothing produced there. So that gene is broken. No globin is produced. Okay, so the common alpha thalassemia mutations that you'll hear about, there are those that involve small DNA deletions and large DNA deletions. The small deletions are the ones that arise from aberrant homologous recombination. Okay, they remove one of the alpha globin genes, and there's two different types depending on how these misalign during homologous recombination. And they're called minus 3.7 and the minus 4.2. That 3.7 and 4.2 is just the number of kilobases deleted there. And these are also called alpha plus mutations because there's still some alpha there, alpha plus. And so one gene deletion alpha thalassemia. And again, these arise from aberrant homologous recombination. Now, one thing to know is that on the sister chromatid, every time this happened in the development of the organism, there was a sister chromatid that had a triplicated alpha globin locus. And that triplicated locus is also passed on, and it can cause problems later that we'll talk about. It's essentially the opposite of alpha thalassemia. Opposite of alpha thalassemia is kind of beta thalassemia, and so we'll see that triplicated alpha globin loci when I talk about beta thalassemia. So keep that in mind. And then the other type of common mutations are the large deletions. This is the alpha globin genes, the two paired alpha globin genes here, and big giant chunks of DNA are missing, and these are called collectively the alpha zero or alpha null mutations. One common type of them of DNA deletion is the Southeast Asian variant, which is shown here. And so you can see they're all large deletions that remove two the paired alpha globin genes. Okay, so alpha thalassemia. How do we mix and match all those together? So the problem is we have 4 alpha globin genes, 2 linked on each chromosomes, and you can see you can have 1 and 2 gene deletions and mix and match. And so what we focus on here is the number of normal alpha globin genes. Okay, so in the normal state, that's 4. When 1 is missing, we call that the alpha thalassemia silent carrier state. Technically, it's a trait, but we don't call it trait. This is the alpha thalassemia silent carrier state. And generally, these individuals have blood counts that are near normal. They may have slightly low hemoglobins or slightly low MCVs, but in general, close to normal blood counts, but near the lower limit of normal. Thalassemia trait occurs when there are only 2 remaining normal alpha globin genes. And the 2 classical configurations in which this can happen are shown here, in which we have 2 genes deleted in cis, or 2 genes deleted in trans. And both of these are clinically indistinguishable. You can do a blood count, blood smear, hemoglobin electrophoresis. You're not going to be able to tell the difference. And this is called thalassemia trait or thalassemia minor. Okay? When we only have 1 remaining functional alpha globin gene, that's hemoglobin H disease. Remember, H is the tetramer of betas. So there's a severe marked deficiency, a moderate to marked deficiency of alpha globin genes. So there's excess beta. And so you make hemoglobin H. You do technically make a little bit of H here, but not enough to detect, and a little bit of H here, but not enough to detect by standard clinical methods. It's only when you have 3 abnormal alpha globin genes missing or abnormal that you get hemoglobin H disease. And the 2 main types are shown here, classical hemoglobin H disease and something called hemoglobin H constant spring, which I'll talk about in a minute specifically. And these are the intermediates. And the majors are homozygous alpha thalassemia major as a cause of hydrops fetalis. Remember, hydrops fetalis is a descriptive term for what happens to the child with the severe anemia. There are other immune and non-immune causes of hydrops. Okay, so minor, intermediate, and major. And there's some old terminology here. For example, if you have 2 genes deleted, they called that alpha thalassemia 1. But if you had 1 gene deleted on the chromosome, they called that alpha thalassemia 2. I think to confuse you. All right, so I'm not going to talk anymore about silent carrier state because it's not a clinical condition, but I'm going to talk about thalassemia minor, intermediate, and major in brief terms to make sure we're all on board. So alpha thalassemia trait, the two most common genotypes or allelic configurations you can see are here. 2 genes deleted either on the same or opposite chromosomes. Neonates are going to have a little bit of BARTs, and they'll be microcytic. Remember, normal MCV for a newborn is about 120. So so less than 95 is microcytic for a newborn. So a little bit of BARTs and some microcytosis, that's consistent with thalassemia trait. In older children and adults, there is excess beta, but you don't detect by clinical assays any hemoglobin H. So BARTs is present in newborn screen oftentimes, but not always, but you won't detect hemoglobin H in typical alpha thal trait. These individuals have thalassemia minor, mild hypochromic microcytic anemia. Significance is, remember that it's common, and remember that there are 2 allelic configurations, and those of especially Southeast Asian ancestry have both the cis and the trans configurations in their populations, whereas those of African ancestry tend to have only the trans configuration and not the cis in their populations. Okay? It's frequently misdiagnosed and treated as iron deficiency, and then of course there's risk to offspring depending on how you mix and match. So I can show you this for alpha or beta thalassemia trait. There's hypochromia, there's microcytosis, there's a bit of anisopoikilocytosis. Not too much in the way of target cells. Tend to see more target cells in beta thalassemia. Now this is very straightforward and simple, but it confuses people and it shows up on board exams. So we need to specifically call this out. So the risk of thalassemia major in the offspring depends on the trait genotype. Here we have 2 parents, both have thalassemia trait. Here we have 2 parents, both have thalassemia trait. Clinically indistinguishable by your standard tests, but in one pair, no risk of thalassemia major in the offspring compared to 25% risk. And then you can also imagine another Punnett square where one parent has this and the other just has a 1 gene deletion, and then you can get hemoglobin H disease. All right. Now, what about hemoglobin H disease? So the 2 main forms to know about are the classical form, 3 gene deletion alpha thalassemia, and then the other is hemoglobin H constant spring, which I'll have a slide to demonstrate that in just a second. These neonates will have a lot more BARTs at the time of birth. There won't just be a little bit of BARTs, there'll be a lot of BARTs. And usually the newborn screening lab will alert you to this, that there's an exceptionally high amount of BARTs, and I think it depends upon the state really, how they communicate that to you. But they'll have a lot more BARTs than someone with thal trait, which is usually in the 1 to 2%. These individuals, babies, will also be microcytic. Remember, 94 is microcytosis for a neonate. As they get older, with the excess gamma chains, they will have detectable hemoglobin H, and that's a fast band on isoelectric focusing or hemoglobin electrophoresis. These individuals can have moderate to severe anemia, but it's very phenotypically variable. Some are quite mild. They all have hypochromia and microcytosis. Some have hepatosplenomegaly, and then you can demonstrate hemoglobin H inclusions by doing a supravital stain, and I'll show you that in just a second. Significance then is that, especially the classical form, there's great phenotypic variability. It's oftentimes quite mild, and it might surprise you if you're unprepared to think about this. And then hemochromatosis from increased iron absorptions and any transfusions you might get. So you can see just a poorly reproduced image of increased anisopoikilocytosis. Here we can see some target cells, some basophilic stippling, hypochromia, microcytosis, that sort of thing. And then you can't see hemoglobin H inclusions on a peripheral smear. You have to do a supravital stain, like BCB, brilliant creasel blue, or something like that, to demonstrate them. So that's not something that you'll pick up unless you specifically ask for this sort of supravital stain. Now, what about hemoglobin constant spring? I've talked about that. This is that exception, or one exception, to the rule that alpha thalassemias are caused by deletions. Here, this is caused by a point mutation. And there are many alpha thalassemias caused by point mutations, but this is a classical one to know about. So here's the alpha globin mRNA and the normal stop codon. Constant spring is a mutation here in that stop codon. And so instead of a stop, you get a glutamine, and the next in-frame stop codon is 31 codons down. So what you end up is 31 extra amino acids on the end of the alpha globin protein. And that's bigger, it migrates more slowly, and so that's a slow band on isoelectric focusing. You might hear about fast bands and slow bands. Fast, BARTs, and H, slow bands, something like constant spring. Now, why has this caused thalassemia? Well, that's because it's so unstable that it's made and then it degrades. And so you can see that this leads to a quantitative deficiency. But there's a small amount that makes it into protein, so it's both qualitative and quantitative. So that's how it's thalassemic. And this is the usual genotype, 2-gene deletion alpha thalassemia in cis, co-inherited with 1 alpha constant spring mutation. And this genotype is a form of hemoglobin H disease that's called hemoglobin H constant spring or alpha thal intermedia or NTDT. And this is usually more severe than classical hemoglobin H disease. That's one thing to remember. All right, homozygous alpha thalassemia is one of the causes of hydrops fetalis. Again, the typical genotype is that there are no mutations. Now take a look here. This is the alpha 2 and the alpha 1 gene. Here's the zeta gene over here. Some of these mutations, big deletions, spare the zeta globin gene. So you might ask, well, how can the fetus survive? Well, if the deletion doesn't delete the embryonic genes, then there can be fetal viability. And in those cases, those fetuses are making nearly all embryonic and BARTs and H. These babies can be rescued by in utero transfusions and postnatal chronic transfusions or stem cell transplantation. So in utero demise, usually if the zeta globin genes are deleted. The possibility for rescuing if the zeta globin genes are not deleted. All right, so that's alpha thalassemia in broad strokes. We'll talk now about beta thalassemia. Remember, in general, beta thalassemia is most likely to be caused by point mutations that disrupt regulatory sequences. And I'm just going to show you this again, that the beta null, that means it's a type of mutation that disrupts expression entirely from that gene. Or beta plus, and there you can have different levels of beta plus. So, just a touch of beta globin is made from that gene, or nearly 30 to 40% of normal is made from that gene. And so, depending on the particular mutation, and mixing and matching with other mutations, you can get differing severities of disease. The one thing to remember is there's not just one beta plus of given severity, but there are beta pluses, mutations of varying severities. Now, there are also recurring deletions that cause beta thalassemia. Probably one of the more common ones we see is the 619 base pair deletion here that we see in those of Asian Indian ancestry. But by and far, the more common ones are the point mutations. In terms of the classical or common genotypes of beta thalassemia, it's a bit simpler because you just have 2 genes, 1 on each chromosome. So the mixing and matching is not as complex. So normal, beta beta. The thalassemia trait or thalassemia minor is just the heterozygous state for either the null or the beta plus. Compound homozygosity for beta null mutations, that's beta thalassemia major or Cooley's anemia. If you get 2 severe beta plus mutations or a beta 0 and a severe beta plus mutation, you can also get a clinical phenotype of beta thalassemia major. But in general, everything else in between the homozygosity for beta plus mutations that aren't particularly severe, or compound heterozygosity for a beta plus and a beta 0 mutation, or co-inheritance of a beta E, hemoglobin E with a thalassemia determinant can give you thalassemia intermedia. These are the common genotypes. And I'll go over, again, trait, intermedia, and major in the same level of description that I went through with the alpha thalassemias. So, beta thalassemia trait, in general, this is a heterozygous state. You can be heterozygous for a beta plus allele or a beta null category allele. Again, neonates, they subsist on gamma globin chains, so neonates will have normal blood counts. They don't have BARTs, they don't have microcytosis, they don't have anemia. They have normal blood counts. As they get older, though, they develop the typical thalassemia trait phenotype, mild hypochromic microcytic anemia. But hemoglobin A2, and I'll point this out in just a minute, is usually increased, and that's one way of making a diagnosis of inclusion of the beta thalassemias, and sometimes F is increased. This is common, again, frequently misdiagnosed and treated as iron deficiency, And of course, risk to offspring depending on whether both parents have beta thalassemia determinants or not. I could show you this for alpha thalassemia, but again, hypochromia, microcytosis, a bit more target cells here, tend to see a bit more target cells in beta thalassemia, and the thalassemic anesopoikilocytosis. Now, one of the things, this is a little bit of a segue, we're trying to do oftentimes clinically is differentiate, does this patient have thalassemia trait or mild iron deficiency anemia? And one of the ways we try to go about doing that is hemoglobin electrophoresis, and that can be problematic. And I'll explain why. So in beta thalassemia trait, F is either normal or increased, but usually hemoglobin A2 is increased in beta thalassemia. So if you see elevated A2 9.9 times out of 10, that means a form of beta thalassemia. There are other causes of elevated hemoglobin A2 that hematologists should know about that are rare, but almost always hemoglobin A2 elevation means beta thalassemia trait. Alpha thalassemia trait will give you either a normal pattern or a low hemoglobin A2. So high A2 beta thalassemia trait, normal or low alpha thalassemia trait. The problem is iron deficiency that you're trying to differentiate from thalassemia trait can give you a normal pattern and even a lowering of the hemoglobin A2. So if you suspect iron deficiency more than minimally, treat the iron deficiency first before you even get the hemoglobin electrophoresis, because it's going to confound things and you're going to have to repeat it anyway unless you just go for genetic testing. So beta thalassemia trait, you can confirm it by electrophoresis with an elevated A2. Alpha thal is generally a diagnosis of exclusion because the electrophoresis may be normal. The problem is iron deficiency anemia on electrophoresis mimics alpha thal by driving down the A2, and occasionally it can blunt the elevation of hemoglobin A2 if you happen to have beta thal trait and iron deficiency at the same time. So the bottom line is treat iron deficiency before performing an electrophoresis. All right, beta thalassemia intermedia, a number of different classical combinations of genotypes that we can see here. I'm going to talk about hemoglobin E on 2 slides in just a minute. Remember, unlike the kids with hemoglobin H disease who are microcytic at birth and have elevated hemoglobin Barts, these neonates have normal blood counts, right? Because gamma, not beta or beta E. Gamma is the predominant beta-like globin. But as they get older, they'll develop a mild to moderately severe anemia, hypochromia, microcytosis. A2 and F will be increased. You can see that's a recurring pattern in beta thalassemias, and some will get hepatosplenomegaly as a reflection of extramedullary hematopoiesis. Some do require intermittent transfusions, and remember, thalassemia intermedia is anything between trait and major. That's a big spectrum. And then all these kids with alpha thalassemia and beta thalassemia intermedia get hemochromatosis from increased iron absorption and also transfusion. Now, how can you get such range of if you only have these 4 combinations, I'm harping on this, how can you get such a range of variation? And that's all beta plus is not the same, right? And I'm coming back to this, the phenotype can be modified by the non-beta globin genes, and I think I'll show that on the next or the slide after that. This is just an individual with beta thalassemia intermedia. You can see marked anesopoikilocytosis, hypochromia, target cells, nucleated red blood cells. This person's had a splenectomy, you can tell, because of these Howell-Jolly bodies here. Okay, so in the normal state, you should have roughly equivalent production of alphas and betas, right? So if you have thalassemia trait, in this case beta thalassemia minor, let's say you have 1 beta null allele, so you just have a little bit of imbalance here. How can you tip this balance even further into intermedia or major? Well, you can decrease the weight and make less beta globins, or you can make more alpha globins. And remember that triplication that I talked about. You can co-inherit, you can be heterozygous for a beta thalassemia mutation, but you get from your other parent or even the same parent a triplicated alpha globin locus. So you can have 5 or 6 alpha globin genes. And so here you just need to remember that when you're diagnosing thalassemia, genetically, you can't just look at the beta globin locus. You have to look at both the alpha and the beta globin locus simultaneously because they affect each other. If you did genetic testing on this person and confined it to the beta globin locus, you'd just say, oh, this patient has beta thalassemia trait, and then you'd be ignoring the mild anemia and hemolysis and that sort of thing. This person has a form of beta thalassemia intermedia due to the co-inheritance on different chromosomes of a single beta mutation and a triplicated alpha globin locus. All right, so hemoglobin E, this is one of the most common hemoglobin variants in the world. Hemoglobin E and S are among the most common structural variants. The mutation is shown here, and the genetic nomenclature is shown here. Classical nomenclature is the numbering is going to be one off from the modern genetic nomenclature. And that's because the modern genetic nomenclature starts with the number 1 is the first codon, which is the start codon, which is ATG, which encodes for a methionine. But after the beta globin chain is produced, the methionine is excised. There's N-terminal methionine excision, and so that's why it's actually, when you number it based on the protein residues, mature protein residue, it's going to be one off. So don't be confused by this. The same thing will happen with sickle cell anemia. It's E7V, not E6V. Dependent, you have to know the nomenclature. And I'll point that out again in a second. So this is another one, like hemoglobin constant spring, where there's both a qualitative and a quantitative defect, a thalassemic hemoglobinopathy. It's very common. Millions of people in the world have it, and most people don't know that they have it. But when it interacts or is co-inherited with beta thalassemia determinants, it can form a disease. And so clinical spectrum ranges from a benign thal minor-like phenotype with hemoglobin E trait, and even those that have homozygosity for hemoglobin E, mild microcytic anemia, generally a lot of target cells. It's only when you co-inherit hemoglobin E with beta thalassemia determinants that you get the potential for more severe conditions. Even E beta plus thalassemia tends to be mild, but it depends on the severity of that beta plus mutation. E beta 0 thalassemia can give you an E beta thal intermediate or major phenotype. And so here, hemoglobin E disease is mild, but E beta 0 thalassemia is clinically significant. Now, why is it thalassemic and a structural variant? So here's your beta globin gene. Here's the point mutation that leads to a substitution of lysine for glutamic acid. And that's fine, but it exposes a cryptic splice site. And so when these beta E globin transcripts are made, some are properly spliced and some are improperly spliced. The ones that are properly spliced give rise to hemoglobin E. The ones that are improperly spliced don't give rise to any mature peptide. So here we have reduced output. And when we have reduced globin output, it's not that means thalassemia. So it's a structural variant that's also thalassemic. Beta thalassemia major, the classical way to get it is homozygosity for the nulla lesions. Again, these neonates are going to be normal. They are going to have no anemia and no microcytosis, but they'll have an F-only pattern. And so that's a clue. An F-only pattern in someone who's not an extreme preemie, that person, even though they have normal blood counts, should be followed very carefully and should probably be suspected of having beta thalassemia major, because in the first 6 to 9 months of life, as gamma chain production turns off, there's no beta production to turn on, and they get progressively severe anemia, and they produce only F and A2, and they'll eventually, if you don't do anything, which you shouldn't, you should do something, they'll develop severe hypochromic microcytic anemia or organomegaly and growth failure. Of course, you want to intervene before then. They'll need lifelong transfusions, or you can always cure them, and then they'll mainly get hemochromatosis from their transfused blood. So, in broad strokes, what's the therapy for thalassemia, especially major or intermedia? Bear in mind that if you put someone with thalassemia intermedia on chronic transfusions, by definition, they're thalassemia major. So look at this terminology conundrum in the box down here. You can review that a little bit later. But you can cure any of these hemoglobinopathies by transplantation. Of course, there are risks and benefits of doing that and limitations in donors. But for the ones that have severe anemia, you generally do chronic transfusion or hypertransfusion therapy. And the common indications are severe symptomatic anemia, growth failure, extramedullary hematopoiesis, And the goals are to alleviate that anemia, suppress that ineffective erythropoiesis, prevent bony complications, and improve growth, quality of life. You do need to do chelation for iron overload, and occasionally you have to consider splenectomy for marked hypersplenism. But we try to avoid that as possible. This is just for you to review in your own time. Now, transfusional iron overload, this is not specific to thalassemia, so it also applies to sickle. But remember, this has been reviewed before. Iron loss is fixed, and when you give red blood cells, you give iron. And then on top of that, there's increased intestinal absorption of iron from ineffective erythropoiesis. And the adverse effects are, I'll show you some slides in just a minute. But there are ways that you can do to limit iron loading during transfusions, especially for sickle, not as much for thal. And so, hemochromatosis. Why is it a problem? Well, you get transfusions and intestinal iron. Iron stores increase. You exceed the capacity of transferrin. That unbound iron accumulates in the organs, and that damages membranes and membrane lipids and causes cellular injury. And this happens in the liver. And so you can see up on the top here the hemosiderin granules and the Prussian blue stain, and this can lead to cirrhosis, liver failure, hepatocellular carcinoma. This can happen in the heart, leading to heart failure and dysrhythmias and sudden death. The most common cause of death in individuals with thalassemia major is cardiac, but also in the pancreas and other endocrine glands where you can get endocrinopathies as a result of the iron overload. Now, we monitor iron overload by measuring the iron in the tissue of interest by MRI, generally. You can measure ferritin, and we do, but look at these caveats down here. And there are different MRI techniques like R2 and T2 star that we convert to a liver iron concentration, or T2 star in the heart, where we tend to just act on the T2 star value. And so we tend to get away from biopsies, and you shouldn't really rely on ferritin alone. These are the two common chelators that are available, deferocyrox and deferoxamine, tridentate and hexadentate. It's important to know that the deferoxamine is the one that's given by sub-Q or IV infusion because of short half-life, whereas deferocyrox is oral. There are actually two formulations now, oral solution and a tablet, and the dosing differs depending on whether or not it's the tablet or the oral solution. They have similar toxicities and similar monitoring, but you do need to be aware of the need for screening for hearing loss and retina and bone changes in long-term deferoxamine therapy. We generally initiate chelation after about 100 to 200 mLs per kilo of red cells, or your LIC, liver iron content, is greater than 5, or your ferritin is greater than 1,500 to 2,000, some combination of those, but oftentimes we wait until after 2 years of age because of the potential for growth failure with early chelation. I just want you to read that by yourself. Now, delta beta thalassemia, what is that? Well, here's your two paired gamma globin chains and your adult delta and beta globin chains. In delta beta 0 thalassemia, well, they're gone. So all you have is your gamma globin chains. And so people with delta beta thalassemia, well, they have high F and low A2 because they only can make F and there's no delta or beta, and delta makes A2. Okay? Delta beta plus thalassemia, that means that there's some gene that's there, but it's a delta beta fusion gene called hemoglobinopathies, and there are variants like it. So they'll also have high F and low A2. So delta beta thalassemia, high F, low A2, and then you might see hemoglobinopathies if it's a delta beta plus thalassemia. Now, related to delta beta plus thalassemia is HPFH, or hereditary persistence of fetal hemoglobin. There are a number of different types of HPFH, and you can classify them as deletional or non-deletional as one classification, where the deletion is of the delta and beta globin genes, and all you're left with is the gamma globin genes. Okay, that looks similar to the delta beta 0 mutation, and it is, and we'll talk about how they're different. But then the non-deletional ones are regulatory variants, usually in the gamma globin chains. And then you can classify them on whether or not that elevated fetal hemoglobin is present in all cells, pancellular, or just in some of the cells, heterocellular. And then the non-deletional forms can either be linked to the beta globin gene cluster or not, and maybe even on different chromosomes like BCL11 and polymorphisms in the HMIB locus and others. And so this is what I'm talking about. Heterocellular, there's just a lot of F in some of the cells, but not all of them, or it's pancellular. Both of these individuals have 25% hemoglobin F. So what's the difference between HPFH and delta beta 0 thalassemia? They both give defective delta and beta globin synthesis. They're large deletions. They both give you increased hemoglobin F, even higher than you see in beta thal trait. They both give you decreased A2, unlike beta thal trait, and homozygotes will have F only, no A or A2. But gene deletion HPFH gives you no thalassemia peripheral blood phenotype. So you don't have microcytosis, you don't have anemia. So hemoglobin F production is upregulated enough to fully compensate for defective delta and beta synthesis, as opposed to the mutation being just a little bit different, where there's not enough compensatory gamma globin chain production to compensate for that. So delta beta thalassemia, you're going to get microcytosis and anemia. Gene deletion HPFH, no microcytosis and anemia. Now, it's important to remember that you can get transient neonatal thalassemias, in utero and transient microcytic hemolytic anemias. Can be a cause of hemolytic disease of the newborn. This is a disease that goes away, as you can imagine. All right, so I said I'd spend a lot of time on the thalassemias because they're more confusing, so let's try to squeeze the rest of this in. The qualitative abnormalities of hemoglobin are shown here. There's only a limited number of ways that hemoglobin can be qualitatively abnormal, and we're going to focus on decreased solubility. We've talked, others have talked about the variance in oxygen affinity and met hemoglobins and instability. We're going to focus here on number one. And these are the common structural variants you need to be familiar with: hemoglobins S, E, C, D, and O, and their mutations and their distributions, and of course, the significance. S gives sickle cell disease. Hemoglobin E, depending on what you co-inherit it with, can give you a thalassemia or a form of sickle cell disease. Homozygosity for hemoglobin C is a hemoglobin anemia, a hemolytic anemia. Compound heterozygosity with S can give you sickle. And then by themselves, hemoglobins D and O don't cause any problems, but when you co-inherit with S, then it can cause a form of sickle cell disease. The boards want you to know how to, and there will be examples of hemoglobin electrophoresis on the boards. Really, so you apply hemoglobin to an electric field, and it migrates along with your controls. And so you look at a lane here, and it's in the S position. The problem is, this is the S position, but other things can be in the S position, like D and G. So you have to do another method where the migration changes. And so, for example, in citrate electrophoresis, D and G migrate in the A position. So really, you need to do at least two methods of electrophoresis to identify a varying hemoglobin. Citrate is usually used to confirm the presence of S or C, but you're really not identifying the hemoglobin, you're just comparing it to the migration of a known hemoglobin, right? So you don't really know what's in that band, you're just comparing the migrations. People don't really use cellulose acetate electrophoresis anymore, except on boards. It's usually replaced by isoelectric focusing because it gives you sharper bands and better separation of some variants, like S and D don't go right next to each other. If you look in the question and answers, there'll be a lot of cases that go over interpretation. And more common current screening first-line methods are more automated, like HPLC or capillary zone electrophoresis. Again, rather than a migration on a band, you're getting elution time or a migration time in a liquid phase. This is something to read about genetic testing. All right, sickle hemoglobin. This is definitely a mutation that you need to know. Old nomenclature, mature protein beta-6 gluval with genetic nomenclature E7V. And so this valine is hydrophobic, of course, and so you know that upon deoxygenation there's polymerization. And that polymerization is mediated by beta-beta intramolecular contacts. That's a board specification, beta-beta contacts. And you can see the valine here interacting with some other moieties there on an adjacent beta chain. And this is a cyclic reversible process that happens, and cycles of this damage the red blood cell membrane. The boards also want you to know that other non-S hemoglobins inside the red blood cell slow or inhibit that polymerization. If you have A in there, that slows polymerization. A is not incorporated into this fiber, but it dilutes out the S. Hemoglobin F is incorporated into this fiber, but then causes a chain termination, so to speak, and that inhibits further polymerization. So F is a better anti-sickling hemoglobin than hemoglobin A. I think this will probably go away soon, but the board wants you to know about irreversibly sickled cells and clinical correlates. I think this is old school There is a phase early on in the red cells, short life of 14 days, that there's reversible sickling, but with progressive cycles of polymerization, depolymerization, there's dehydration, membrane damage, leads to these dense, irreversibly sickled cells. That's what you see on the peripheral smear. Okay, sickle cell disease is not one disease, but a collection of diseases that have in common sickle hemoglobin. The four most common types are shown here in order of decreasing frequency: sickle cell anemia, beta S, and sickle beta 0 thalassemia. These are the two most severe forms of the disease in general. More severe anemia, more reticulocytosis, a higher frequency of clinical complications. In between, we have the compound heterozygous states, SC, and sickle beta plus thalassemia, less severe anemia. Anything with thal in the name as a clue has low MCV. And then the SCs and the S beta plus, less severe anemia, less severe reticulocytosis. But overall, the severity is decreased. And then the inheritance is, you can either think about it as autosomal recessive for SS disease or codominant for SC and the others. It's important to know that the incidence of all the different complications of sickle vary by the genotype. And these are old data from the cooperative study of sickle cell disease. And it's really just look at these numbers here. Everything is more common in SS than S beta 0 thalassemia. That's the bottom line. But people with SC and S beta plus still can have all those complications, and when they do have them, they can be just as severe. But on a population basis, they're much more common in the SS and S beta 0 thalassemia. Almost everything, with the exception of, for the boards, retinopathy is more common in SC than SS. And then in SC disease, the splenic involution is delayed. It's not at birth, but by 4 to 5 years of age. And the kids with SC have splenic involution and infarction and splenomegaly as older children and adults. AVN is also common in SC, but not necessarily more common in SS. There are light microscopy differences as well. Many irreversibly sickled cells in SS. And in SC, you tend not to see irreversibly sickled cells, but dense contracted cells and target cells. So you can have someone without sickled cells on the peripheral smear who has sickle cell disease, and typically that's someone with SC disease. In broad strokes, what does sickle cell disease cause? Well, there's a chronic hemolytic anemia, and as a consequence of that, there's jaundice, pallor, fatigue, susceptibility to parvovirus aplastic crisis, increased risk of cholelithiasis, just like any other hemolytic disease, and endothelial dysfunction due to nitric oxide quenching. And then on top of that chronic hemolytic anemia, punctuated episodes of pain, acute complications like pain and dactylitis like we see here, or large hemispheric stroke, splenic sequestration, aplastic crisis. And then behind the scenes, building up over the decades, is chronic organ damage. And then especially important for the young kids, the neonates and the very young children, increased susceptibility to infection because of hyposplenism. So then again, in broad strokes, what are the components of management of sickle cell disease that the boards want you to know about? Well, a cornerstone is early identification by universal newborn screening. And combined with that is ongoing lifelong education. Because if you want to identify them, to put them on prophylactic penicillin so they come in and see you in case of fever. If you don't educate the families what to do in case of fever or splenomegaly, then the early identification has been for all for naught. So early identification paired with preventive and screening measures, which we'll talk about, and then most importantly, disease-modifying therapies that need to be the cornerstone of the management. And then if you're not on good disease-modifying therapies, and occasionally even when you are, management of acute complications. The spleen is an important organ, of course, in sickle, and you can either have hyposplenism and involution causing problems, and because of involution, which begins at as early as 3 months of age, there's a lifelong risk of bacterial sepsis, especially pneumococcal. That's why we do newborn screening. That's why we do prophylactic penicillin. Immunizations are important, and why fever is a medical emergency. And then splenic sequestration, that's partial or partially reversible entrapment of red cells in the splenic pulp that can lead to mild to severe acute anemia. It can be recurrent, and that's why we need to teach the families, the parents, to palpate the spleen. Occasionally, we need to take out the spleen. Now, sickle cell anemia can be complicated by acute anemia, either by the transient aplastic crisis or parvo crisis, or acute splenic sequestration. And they both can cause anemia and, if severe, shock. And it's important to differentiate the two because the treatment is different, right? You need slow transfusion for severe transient aplastic crisis, whereas you might need a rapid transfusion because of hypovolemia. How can you differentiate the two? Spleen is generally not enlarged from baseline in aplastic crisis. There'll be reticulocytopenia, no nucleated reds, normal platelets, and oftentimes decrease in jaundice. I ask about are Johnny's eyes less yellow than they used to be? And then splenomegaly with acute splenic sequestration, reticulocytosis, nucleated reds, and thrombocytopenia from the hypersplenism. Now, to make things tricky, if you catch the aplastic crisis in rebound, in recovery, then there's going to be brisk reticulocytosis that can confuse you. And then sometimes parvovirus can trigger this, but also trigger splenic sequestration. Now, it's important to know that fever is a medical emergency because of hyposplenism, increased risk of bacterial sepsis, 400-fold over otherwise normal kids. And here are some empiric management guidelines. The bottom line is most kids can be managed as an outpatient with long-acting antibiotics. These are some higher risk features that might guide your strategy to admit or not, but they all need outpatient management. We'd like to prevent sepsis rather than treat it, and so here are some common ways to give penicillin, the most common ways, and a number of immunizations that we know we need in addition to the pneumococcal, meningococcal and HIV vaccines. And importantly, we need to emphasize the importance of fever. If the parents don't bring the child to medical attention for fever, then that's a big problem. Acute painful episodes, these are some features in management that the boards want you to know about. Triggers of pain, oftentimes none, but there may be infection or inflammation, cooling of the skin, or even psychosocial stress. Tends to be musculoskeletal pain or abdominal pain, but most of the time there are no physical signs of the pain. In 15%, there might be some tender swelling, for example. Ideally, we'd like to prevent pain by avoidance of dehydration and cooling of skin, overexertion, avoiding these things, and then disease-modifying therapy like hydroxyurea. I'll point you to this New England Journal article offline. And management, the most important thing is that you individualize the pain management, and you need to avoid over and under treatment of pain, right? And then in addition to non-pharmacological adjuncts. You want to correct dehydration, but don't cause overhydration. And then incentive spirometry in particular to prevent acute chest syndrome, which is a basket term for an acute pulmonary illness in someone with sickle cell disease, characterized by a new pulmonary infiltrate and some respiratory signs or symptoms. And when kids and adults that have chest syndrome, about 30 to 60% of the time it's not apparent at the time of hospitalization. Most of the time the kids that we see, they're young kids with transient viral infections that do okay, but it is a common cause of hospitalization, and it can be severe and progressive and fatal, especially in teens and adults. There are a number of inciting causes that we aren't good enough to differentiate on the individual patient basis, so there's empiric management with antibiotics, and then transfusion. Usually not needed for the very young with mild disease, but if there's hypoxemia or exacerbation of anemia, you can give simple transfusion, severe disease, exchange transfusion, and then you'd like to prevent it, for example, in the pre-op state with simple transfusion. And then some supportive care guidelines here. Sickle cell can also affect the brain. Overt stroke we've talked about, silent cerebral infarction, TIAs, that sort of thing. These are things to at least be familiar with. I'm going to talk about the two most common ones, which are overt stroke and silent stroke. Historically, 10 to 11% of kids with sickle would have an overt stroke by 18 years of age. And once you had one, the recurrence rate was 50 to 90%. And so the way to prevent the second stroke was chronic transfusions. Now we know that hydroxyurea is not a good substitute for secondary prevention of overt stroke. But we can do primary prevention with both chronic transfusions or chronic transfusions followed by an overlap to hydroxyurea. And these are the trials indicated below here. Silent stroke is still a huge problem. 20 to 40% of individuals at least have these. They're associated with neurocognitive and academic impairment. Secondary prevention, the SIT trial showed us that chronic transfusions can do this, but primary prevention is not known or is experimental. So how do we screen and prevent stroke? We do it by TCDs, at least yearly between ages 2 and 16. And then if there are abnormal velocities, recommend chronic transfusions. And these are, Going the wrong way. Somebody wants me to finish up, but I will. The higher the velocity, the higher the risk of stroke. The actual numbers, 170, 200, that depends on the imaging technique that the TCD technique that you're using. So pay attention to these footnotes here. The Twitch trial again showed us that hydroxyurea is not inferior to chronic transfusions for primary stroke prophylaxis, but that the inclusion criterion is not stroke. It's abnormal TCD velocities, no other abnormalities on the MRI. You can't have severe vasculopathy. You still have to give transfusions for at least 12 months and then an orderly overlap. If you do happen to have an overt stroke, the initial therapy is really rapid triage, supplemental oxygen, and mainly avoidance of delays to transfusion. Transfusion is what you want to do. Erythrocytophoresis is the best likely, and then secondary prevention we've alluded to here. The boards want you to know about priapism and home management. If you do have an episode, oral analgesics, oral hydration, a warm water, a bath, urination, and then pseudoephedrine can sometimes terminate the event. And for prolonged episodes, then really we want aspiration and irrigation events. And then there are some methods by which you can prevent priapism. If it's recurrent, acute transfusion is probably not helpful, though. The kidney is affected by sickle cell disease, unsurprisingly. There's reversible, and it depends on the age, from urinary concentrating defects to glomerulopathy, tubular acidosis, and even end-stage renal disease, which is associated with high mortality. There's some small studies of ACEs and ARBs, but the jury is still out there. These are some of the long-term complications to know about. They just want you to know that this can happen. And then finally, disease, near the very end here, disease-modifying therapy. This is hydroxyurea. It's preventive therapy for all. I'm just going to mention that the indication is SS disease. The indication is SS disease, at least. You don't have to throw in an X number of episodes of vaso-occlusive crisis or what have you. The main mechanism is induction of hemoglobin F. It's a once daily oral formulation. You can start low and go high, or do a PK model and start at the right dose. Toxicity is very mild, but it does require monitoring of CBCs. And everything that can happen in sickle cell disease is less when you're on hydroxyurea. And we know that it prolongs life, both in children and adults. So if your patients aren't on it yet, then they need to be on it now. Transfusions, you can divide this as either episodic or acute. Chronic transfusions is really, we're talking about disease-modifying therapy. The main indications are stroke, primary and secondary prevention, or recurrent problems, severe problems. And like thal, this is regularly scheduled transfusions. The main complications, again, iron overload, we've talked about alloimmunization, and so to prevent that, extended antigen matching. Now, when you give simple transfusions, you need to avoid overtransfusion, and so why is that? So in everybody, there is a relationship that's linear between hematocrit and viscosity. So as hematocrit goes up, viscosity goes up. But if you throw on increasing mixtures of hemoglobin S, there's an inflection point at a hemoglobin of 10, hematocrit of 30, so that with increasing viscosity, blood flow, oxygen delivery then falls. And so the magic point in the untransfused child with sickle cell anemia is don't go higher than 10 to 11. If you have chronically transfused kids, if you check their hemoglobins after transfusions, they may be 12 or 13, but then you have their hemoglobin S down that low. This is really for the untransfused kids. You can cure, again, sickle cell and thal. The problem is chronic graft versus host disease, limitation of HLA-matched siblings, and there's lots of ongoing research to expand donor choices and reduce toxicities. The boards also want you to know that the current life expectancy for males and females is about in the 50s, and in SC, that's always approached normal, and they specify in the content outline that S trait has a normal life expectancy. Now, there are other forms of sickle cell disease, other compound heterozygous states, S with other beta hemoglobinopathies and beta thalassemias, just to be aware of. Sickle cell trait, one slide. There are a number, you look at all these things that can happen with sickle cell trait. You think it's a horrible thing, but millions and millions and millions of people in the world have it and have had it over the centuries. It mainly causes some renal adverse events, such as microscopic hematuria, mild concentrating defect, that sort of thing. Some weird things like glaucoma after hyphema. And then very rarely, but what you hear about on the news every now and then, is splenic infarction, renal medullary carcinoma, or exertional heat illness or rhabdomyolysis death, which can be prevented by maintenance of normal hydration and prevention of overheating. 2 last slides. The ABP wants you to know how to differentiate SS from S and compound heterozygosity for hemoglobin S and gene deletion HPFH. So in this state, we have on one chromosome beta S, on the other chromosome there's no beta, okay? But it's different than beta 0 thalassemia. Both newborn screening patterns will be SF. Both hemoglobins present later in life will be more S than F. But the F is variable in SS disease, but consistently elevated in HPFH. But the distribution of hemoglobin F is heterocellular in SS disease, even when elevated, but it's pancellular in gene deletion HPFH. So the pancellular distribution of this elevated F eliminates anemia and microcytosis, okay? So it's the pancellular distribution. This person can have 30%, this person can have 30% F, this person will have anemia and reticulocytosis and problems because not all cells are protected. This person won't. And the other thing they call out is how do you differentiate sickle beta plus thalassemia from sickle cell trait? Newborn screening pattern will be FSA as opposed to trait FAS. There's more A than S, so that's sickle cell trait. And sometimes in sickle beta plus thalassemia, there's not enough beta and not enough A present to be detected, so sometimes it's an FS pattern. But beyond that, there's more S than A in sickle beta plus thalassemia and more A than S in sickle cell trait. And of course, these have normal blood counts. These people have anemia, microcytosis, and reticulocytosis. And the last slide is hemoglobin C disease. Homozygosity for hemoglobin C is not a sickling disorder. Mild chronic hemolytic anemia, intermittent jaundice, but some of these individuals can have splenomegaly, especially adolescents and adults. But they don't have hyposplenism, they don't need antibiotic prophylaxis, and they don't have splenic sequestration. They may have splenomegaly and it's some hypersplenism, but they don't have reversible sequestration. On peripheral smear, microcytosis target cells and hemoglobin C crystals. That's it. Sorry I went over a few minutes.